Intrapartal complications or dysfunctional labor, where we talk about the problems divided up into the 4 P's. Problems of the power, problems of the passenger, problems of the passageway, and problems of the psyche. Hello, this is Susan Knowles from Cochise College Nursing, and thank you for joining me on this podcast where we'll talk about problems that cause complications of labor or dysfunctional labor. Problems of the power or powers relates to problems with the mother. This is the first in a series of podcasts related to problems of the power, passenger, passageway, and psyche, which will continue our P thing. The question is, does mom have ineffective contractions, or does she have none at all? Or is she completely dilated, but she has no more energy to push for her delivery? Some of the conditions discussed in this podcast will relate to problems of the passageway, passenger, and the mom's psyche. So, mom has reached 40 weeks, and she either has no contractions whatsoever, or she has ineffective or weak contractions, and they're too uncoordinated to make any progress. Or the uterus is just too big, either because it's got more than one baby in there, multifetal pregnancy, or because she has too much fluid or polyhydramnios. In this case, the uterus tends not to contract well. It's just over-distended, and it causes the labor to be slow, or the contractions just not to be very effective. It can add to the maternal frustration and fatigue because labor just keeps going on. But sometimes even after the labor has begun and she's in active labor, it just remains slow. And then when the mother actually does get completely dilated, when she tries to push, she's just ineffective. And that could be from fatigue, can be because of fluid imbalance, hypoglycemia. It could also be because she's gotten analgesia or anesthetic at the wrong time. Because when pain medication is given at just the right time, it seems to actually speed labor up rather than slow it down. If it's given too early, something like Stadol given too early in labor, it'll actually slow the labor down. But if it's given just at the right time, it'll actually speed things up. However, if it's given late in the labor process, the baby may be born and still have that opioid effect, and then you'll have to deal with a baby that doesn't want to breathe or is extremely sleepy. Pain can actually prevent a mom from working with her contractions and or with her delivery. So we're going to talk about some of the interventions in a moment, but before I go on, one more thing, and that is CPD, cephalopelvic disproportionment. That means that the baby is just too big to come through mom's pelvis, or later when we talk about the passageway, it could be that the pelvis itself is shaped in a way in which the baby is not able to mold and get through that pelvis. So moving on to the interventions, what can be done? Well, one of the things that can help to speed labor up oftentimes is an amniotomy. An amniotomy is where the amni hook is used, a plastic little hook with a sharp tooth, if you will, at the end, and there's a picture of it on this slide, is used to actually break the bag and help to let the fetus come down and be better applied to the cervix itself. Sometimes we'll talk about what the problems can be, and it is very important at the time of amniotomy that the nurse assess fetal heart tones, and assess for the amniotic fluid itself. Is it clear? Is it cloudy? Does it have a foul odor? Does it already make you start thinking, oh my goodness, this woman may have an infection? Is the head well applied to the cervix now, or has the cord slipped down and actually the mom is at risk for prolapsed cord, especially if the baby is very high in the pelvis. It is not well into the pelvis, so if she's at a -3 station or very, very high, this is a potentially dangerous situation and sets her up for a prolapsed cord. So, but an amniotomy, if when it is performed, and it is performed very frequently, it can help to speed labor up. Also, hydrating the mom, giving her IV fluids and oral fluids to help correct her dehydration will actually help the uterus to be more effective and make those contractions more effective. Pain management, as I mentioned before, can actually speed her labor up if it's given at the right time. Either an epidural, or today Stadol is the drug of choice that seems to be given most frequently. We can also, as nurses, provide opportunities for the mom to get some rest. So we may need to be the person who is encouraging her to have less frequent visitors, or just her support person there to help her get the rest that she needs to make her more effective when the time comes for actually pushing the baby out. Position changes will help promote better perfusion, so that's important that she be changed, her position be changed frequently, every 30 minutes or so. And then communicating with her to see if anxiety is actually part of what's going on, to prevent her from being effective and working with her contractions that she is having, and giving her the support that she needs, or making sure that her support person is there with her. If those contractions are still not very effective, then her labor can actually be augmented by adding Pitocin in her IV. And remember that Pitocin is always given as a secondary line so that it can be shut off if needed. And rather than truly an induction where she's not started with any contractions at all, she's actually having contractions, so we're going to help to make those contractions stronger and more effective by adding Pitocin. So that's what an augmentation is. And if mom reaches 40 weeks and actually has no contractions or no obvious contractions, nothing's changing the cervix, then an induction might be done. An induction is where she is given Pitocin through her IV bag to actually cause contractions to start, and it is gradually titrated or increased. The dose is increased to the point in which she has a good contraction pattern. Contractions that are approximately every 3 minutes apart, that are lasting at least 60 seconds and no longer than 90 seconds. But before that point, we need to see whether or not she actually is favorable for induction. And one thing that can be done is to do an assessment by using a score called the Bishop score. And the Bishop score is looking at how far dilated she is, what is her cervical length, the position of the baby, the station of the baby, and her effacement, or how firm or soft her cervix actually is, to see whether or not she's favorable. And the higher her Bishop score, the more favorable she is for induction. Now, should the cervix not be favorable for induction, it is not soft, it's very firm, it's closed, it's long, the baby is high, then one of the things that is done today is cervical ripening. So a prostaglandin gel, or not necessarily a gel, but some of it comes in the form of a gel, but prostaglandin can be inserted either into the cervix, excuse me, not into the cervix, but next to the cervix or in the vaginal canal. And some of those are Cervidil, Cytotec, Prepradil. Any of those three are the most prominent names. Those can be inserted into the vagina or next to the cervix, as I said. And the night before, they want to start the induction. And what these actually do is they help soften the cervix, which makes it more favorable for the oxytocin induction the next morning. Some physicians prefer just to give one of the gels and use that in and of itself for induction, and that can work as well. Problems with the passenger. We're talking about the baby right now. Now, these are problems with the baby that can set the mom up for having dysfunctional labor. If the baby is too big, we call a baby that's too big in general being one that's macrosomic, because it's just too big to fit through the passageway or the pelvis. And this is usually when a baby is greater than 4,000 grams, or somewhere between 8.5 pounds to 9.5, or almost 10 pounds, or greater. But in truth, any baby could actually be too big to fit through a mom's pelvis, depending on the mom's pelvis, and we'll talk about that next when we talk about the passageway. Or it could be that the baby is in a malpresentation. Any abnormal fetal presentation could actually set the baby up for causing the mom and baby to have a difficult time for this baby to deliver. A malpresentation can be when the baby is in a breech presentation, or when it's trying to come butt first, or feet first, or 1 foot first, or when the baby is transverse, in a transverse lie, when the baby is going east-west instead of north-south, or when the baby is occipitate posterior, meaning that the baby is face up rather than face down, and sometimes we call that sunny side up. And when a baby is persistently in the occipitate posterior position, they're trying to go around the mother's sacrum and coccyx with the back of their head. So you have bone to bone, and the baby and the pelvis do not mold together. So this can be a very, very painful labor, and this is the perfect situation for an epidural, because it is just so painful for the mom when she's having contractions. And so what we can do as nurses is to help this OP situation, is to change her position frequently. And some of the positions that we might use would be have the mom sit or kneel or lean forward with support. And she could do that where if you you raise the head of the bed all the way up, and you get her on her knees and she leans over the back of the bed. You can have her rock the pelvis back and forth while she's on her hands and knees, or actually get in a squatting position. Sometimes this will help to get that baby to move out of the persistent occipitate posterior position. Sometimes when you have shoulder dystocia, where the head of the baby's head is delivered and then you cannot get the shoulders out. And this is where you need to use the McRoberts procedure to help spread the pelvis and allow the shoulder to come out. And we'll talk more about this in another podcast where we talk about the intrapartal complications. Multifetal pregnancy we've talked about before, but also when you have twins, triplets, or more, it causes that overdistension of the uterus and it just doesn't contract well. But it also causes oftentimes the babies to be in a mixed position or a lie. So one may be vertex and the other one may be breech. And this can actually add to problems trying to deliver these babies. There are other conditions where there's fetal anomalies, like the baby has hydrocephalus, where the head is really, really large, and this prevents normal descent. or if the baby should have some sort of defect or tumor, excuse me, is what I was thinking of. So again, some of the interventions, as I mentioned before, are those position changes and the procedures of the McRoberts, which we'll talk more about. Or it could be that if the baby is in a breech presentation, that they'll do an external version. And remember, in an external version, this is where using ultrasound to look for the position of the baby and to ensure that the fetal heart is beating normally. The mother would also be monitored on the external fetal monitoring for about 30 minutes or so before the procedure. She'll also be given a dose of tributaline. Remember, tributaline is a medication that is used subcutaneous in this case. Can be given IV, sub-Q, or orally, but in this case it would be given sub-Q. And this will help to prevent contractions during the time in which the physician attempts to rotate the baby into a vertex or cephalic presentation. And problems with the passageway. Well, the passageway is actually the pelvis or the bony pelvis itself. And the good thing about that bony pelvis is that there is a piece of cartilage that runs right down over the pubic symphysis, which does allow the pelvis to expand a little bit. And then, of course, the baby helps us out because the baby has the soft skull. The bones aren't hard yet, and the suture lines can actually override themselves to allow that head to mold to the pelvis itself. But we also note that there are about 4 different primary shapes to the pelvis, and those shapes are gynecoid, android, anthropoid, and palatopoid shapes. The very best pelvis, shape is the gynecoid shape. Well, that makes sense because we call women, our OBGYN is gynecology and gynecoid, so that's a good way to remember it. Now, that is the optimal shape for delivery. Does that mean that a woman cannot deliver vaginally if she has a different shape of the pelvis? No, but the prognosis for delivering vaginally with an alternate shape of a pelvis is lower than it is with a gynecoid shape. Now, are there other reasons that there are problems of the passageway? Yes, there can be soft tissue obstructions. It can be that the pelvis itself is just small, or, as I mentioned, it's in a different shape than the preferred shape. Or it could be that the bladder itself, being that soft tissue kind of thing that's in the way, can actually inhibit the descent of the fetus. But that's easy enough to deal with because the patient can be straight-cathed, or she can empty her bladder, and this will help to prevent that obstruction in the way of descent, and she can go ahead and deliver vaginally. So how do problems of the psyche actually get in the way or cause problems with labor or cause dysfunctional labor? Actually, physiologically, if a mom is extremely anxious, or if she has excessive or prolonged stress, it can actually cause her to increase her glucose consumption. It reduces her energy so that her uterus does not contract as well because she's secreting catecholamines in epinephrine and norepinephrine, which actually inhibit uterine contractions, and they actually act like a tocolytic effect like tributaline. So what can we do? What are the nursing interventions? What can we do? We can actually create a more relaxing environment for her. We can increase her position changes, reduce the noise, intervene with therapeutic touch and a therapeutic relationship, and talk with her, and use both pharmacogenic pain management as well as non-pharmacogenic pain management, like massage. We can actually keep those people that support her around her as well. This concludes the podcast on the problems of the powers, the passenger, and the passageway. Please join me on the next podcast where we'll talk about intrapartal complications. Thank you. This is Susan Knowles from Cochise College.